I will be speaking about dermatologic adverse events to therapy. And as a dermatologist, I'm clearly outnumbered here, so I will refrain from using terms such as progression-free survival or overall survival. And I will be showing you a lot of pictures of pimples and rashes. So as a matter of disclosure, pretty much every company and agent we will be discussing, everything is off-label in the next 20 to 30 minutes. But first, as a matter of background, I would like to start by saying that the remarkable contributions that you have made to your patients by prolonging their lives or curing their disease through the use of monoclonal antibodies or small molecules or cytotoxic agents has been a remarkable effort that has led to the approval of a number of agents in the past several decades. And whereas you see these mechanisms as a way of targeting these patients' disease by targeting these dysregulated proteins or pathways involved in malignant tumors, the way I see it as a dermatologist is that you are targeting the skin, hair, and nails. Because those same pathways or proteins that are involved in the majority of solid and liquid tumors are also critical for the normal homeostasis and functioning of skin. And we saw yesterday how the skin functions and how it works, but what this figure here illustrates is that irrespective of whether you use a monoclonal antibody or a small molecule, what the toxicity will depend upon is what is the protein or pathway that you are blocking. As in consequence, this will lead to a constellation of dermatologic adverse events that will be consistent among a class of drugs and will appear in the majority of patients. But what is the importance of dermatologic events in your patients? Well, of the 1.7 million people that are diagnosed with cancer in the US, as you know, about 2/3 receive chemotherapy, about half receive radiation, and most will have a surgical procedure as part of their diagnosis or treatment. Even before you institute these interventions, 45% of your patients will have some type of dermatologic condition. These conditions, the most frequent ones include infections such as tinea pedis or fungal infection in the feet, onychomycosis or fungal infection of the nails, xerosis or dry skin, pruritus or itching, and bacterial skin infections, all of which can be exacerbated through the interventions that you institute to treat their malignant disease. So when these conditions either become exacerbated through the treatments or novel conditions or toxicities appear in your patients affecting the skin, hair, and nails, they can have a significant impact in their quality of life. This impact is considered to affect 4 distinct areas. The first is the psychosocial impact, because they usually affect areas of the body that are exposed to other people, thereby people feeling they lose their sense of privacy and they have to disclose their diagnosis of cancer to everyone they are in contact with. Secondly, they carry a financial burden. Many of the topical medications we use to treat dermatologic disease are not covered by insurance carriers or have a high copay, limiting our ability to mitigate these events. Third, and it's something that perhaps is not known to people outside of the dermatology world, is that many of these skin conditions can be significantly painful, can make people lose sleep, for example, when they have severe pruritus through the night, and they can also develop infections that can be life-threatening. Thereby, all these conditions can affect physical health and the importance as to why to treat them. And finally, as most of you know very well, better than I do, they can lead to inconsistencies in dosing. And as you know, any patient that develops a severe toxicity or grade 3 toxicity, in most instances, you will interrupt therapy and then you will restart therapy at a lower dose. And one does not know if treating patients at a lower dose than that at which the drug was studied will lead to a lesser clinical outcome, or also can lead to alterations in the benefit of these patients and to an increased anxiety. Many of the patients that I have referred at our institution feel very nervous when their oncologist decreases the dose of their drug because they feel it may not be as effective. This is something that we hope to prevent through the use of prophylactic interventions against these toxicities. So why are we focusing today, and I would like to thank Dr. Butler for the invitation, on toxicities to especially novel agents that have been approved in the past decade or so. Because when you compare the toxicities affecting the skin, hair, and nails that occur with cytotoxic agents compared to targeted agents, it seems like with the new targeted agents, people are more affected in terms of their quality of life when it comes to dermatologic structures, so the skin, hair, and nails. And evidence to that is the study published a few years ago. Alex Rosen is now a resident in dermatology, and she worked with me, and what she did is she gave a quality of life questionnaire called the Skindex 16 to 283 cancer patients receiving either cytotoxic agents or targeted therapies. And what she found was that 52% of these patients receiving cytotoxic agents developed some type of dermatologic toxicity compared to 72% of patients receiving targeted therapies, and that the impact on quality of life as measured by a greater Skindex 16 score was higher in patients receiving targeted therapies, a difference which was significant. And this quality of life questionnaire has 3 different domains. It has 16 questions that measure the impact on symptoms such as pain or pruritus, emotions, or how it affects a person in terms of emotionally the toxicity, and then the functional component. And what she found was that the significant difference was found in the emotional component, because usually targeted therapies, as you know, affect people's face and areas of the body that are exposed to other people, as we will see in the presentation. And she found that acneiform rash and pruritus had the highest impact on quality of life. And today I hope to share with you some data on these 2 topics. So also another reason that I would like to speak about new or novel targeted therapies and their toxicities is perhaps the reason why Sir William Osler said at the time, as you know, he's considered to be the father of modern medicine, that he would always recommend to take the newest medicine first before the effectiveness wears off. So one of the newer generation of agents approved in the past decade were the epidermal growth factor receptor inhibitors. As the name implies, it's the epidermis that carries this receptor. Therefore, 70 to 90% of your patients will develop this acneiform rash affecting the face, chest, scalp, and the upper back. It is severe in about 1/3 of patients, and I would not rely on the randomized controlled trial data on toxicities, because what we have seen time and time again is that in the post-approval setting, the frequency of toxicities reported is greater. That said, however, it's still significant in these patients. You can see here, it is followed by post-inflammatory changes such as crusting, hyperpigmentation, which can significantly debilitate a person during their treatment if they are not treated prophylactically. Another, I think, misconception is that these are reversible events. Well, as you can imagine, after you have had this degree of inflammation in your skin, if people live long enough, they will have scarring of their skin or severe discoloration that will last for the rest of their lives. This is a similar rash that occurs with the newly introduced MEK inhibitors. You may have seen outside there was a booth indicating the use of Pazopanib, which is one of the recently approved MEK inhibitors, but also Trametinib, which is the competing agent, also leads to the appearance of a rash similar to EGFR inhibitors in about 2/3 of patients. The good thing about the newly approved agents is that, as with other toxicities such as squamous cell carcinomas or skin cancers appearing with the BRAF inhibitors, when you combine MEK inhibitors with Dabrafenib, which is the BRAF inhibitor from the same company, you get a lower incidence of rash. And this is likely due to the paradoxical effects on the activation of the epidermis. The main difference between skin toxicities between Trametinib and Dabrafenib and the other agents, competing agents, Pazopanib and Regorafenib, is that Regorafenib is much more toxic as it pertains to the skin, and it is much more sensitizing. So here, where you have such beautiful weather, if one were to choose one, I would choose Trametinib and Dabrafenib, as you don't have the problem of the photosensitivity. More on photosensitivity later on. Pertuzumab for breast cancer, also because it blocks EGFR, causes a rash, although at a lesser severity, about 25%. This is a woman treated with pertuzumab, and this is a man treated with Vandetanib, which also blocks the EGFR, which is an agent approved for medullary thyroid cancer. Lapatinib also causes rash in about half of patients, and not as severe as with single-agent EGFR inhibitors. Herceptin, we thought, did not cause this acneiform rash, but and I don't think it really does cause a rash, only under special circumstances. And there's only been about 5 case reports of a rash to Herceptin, but if you see your patient on Herceptin that tells you that she's having acne, I would believe them, or a patient with GE cancer. In randomized trials, the incidence was only about 12%. It's important to keep in mind also that the administration of EGFR and MEK inhibitors will cause an immunosuppression in your patient's skin, in addition to drying their skin out, which allows for greater susceptibility to infections. A study was conducted showing that in over 220 patients treated with EGFR inhibitors, almost half of these patients developed secondary bacterial, viral, and fungal infections, some of the examples of which are shown here. A higher risk, not surprisingly, was seen in leukopenic patients. So every time you see one of your patients, if there is one thing that please, I would ask you to please remember, and you see any lesion that is either yellow, crusting, or discharging any fluid, is culture. Do a bacterial swab culture, because you will be surprised at the different types of bacteria, non-staphylococcal bacteria that your patients have, and that is perhaps why they are not responding to Keflex, which is what the majority of these patients were on when they were referred. Also, it's important to note that one must grade this rash very critically and very specifically. For example, we as dermatologists are used to seeing rashes and skin conditions, so we may be less impressed by them. And this is evidenced by this study in which over 100 oncologists and 40 dermatologists were given the photo of this man with an acneiform rash. And when they were asked to grade the rash as being severe, 35% of oncologists graded it as severe, whereas only 20% of dermatologists. And further, they asked if they would recommend treatment delay because of the rash. And 14% of oncologists recommended treatment delay, and only 7% of dermatologists recommended treatment delay, so half of that number. In general, what I would say, what I've learned in my experience is that the majority of patients that I have referred by an oncologist that would like to interrupt therapy, they really do not need to have their therapy interrupted, because you can manage the toxicity despite them staying on therapy, and that would prevent the patient from having to start at a lower dose. And also, I think it's important because I think many people, and it's understandable, many people still consider that, okay, a patient develops a toxicity, I will stop the drug, wait 2 weeks, and have the patient come back. The problem with that is that in the majority of these skin conditions, and perhaps many other toxicities, if you don't treat the toxicity is going to take much longer to go away, or when you re-challenge, even at a lower dose, the toxicity will come back. So my suggestion is always even if you have to interrupt therapy, always treat the toxicity, especially those of the skin, because it takes the skin at least 28 days to completely renew itself, as we saw yesterday. So it would take you about at least a month for most of these toxicities to resolve. So what can you do in the prophylactic setting? Well, a study was published in JCO in 2010 that we conducted, in which we took patients treated with panitumumab for colorectal cancer and administered doxycycline 100 milligrams twice daily, plus topical steroids and moisturizers for the first 6 weeks of therapy in all panitumumab-treated patients. So we're talking here about patients that were prophylactically treated. And the primary endpoint of this study was grade 2 or worse skin toxicity. And what you can see here is that when you treat patients prophylactically, you get a greater than 50% reduction in grade 2 or worse skin toxicities by treating them prophylactically with doxycycline and a topical steroid to the face and chest. The odds ratio, of course, favoring that group. Furthermore, when you look at grade 3 toxicities, you can see that the acneiform rash was reduced more than 4-fold. Pruritus was mostly abolished, as was grade 3 paronychia, and the secondarily infected rash, which is very painful, and I just showed you previously, was reduced by almost 3-fold. So again, I think this supports the notion of treating patients on EGFR monoclonal antibodies prophylactically. In addition to that, a post-hoc analysis of these patients showed that it wasn't only the skin that benefited from these interventions, but patients appeared to have less diarrhea, less neutropenia, and less dehydration. So perhaps maintaining that intact barrier of the skin, you are better able to maintain your patients on therapy, reducing the neutrophils going into that inflammatory state of the skin, reducing dehydration, And the diarrhea, I think, could be explained because these patients were also on irinotecan, and perhaps the alteration of the gut flora with the doxycycline may explain that phenomenon. This study was supported by a more recent paper. This just came out last year from Barb Milosky from Vancouver. She took patients on erlotinib. It was called the Pan-Canadian Rash Trial. Patients received minocycline on day one in the prophylactic arm, or they were treated reactively or under observation. And basically, what's important to take from this study is that the incidence of grade 3 rash was greater in arm 3, 34%, when compared to less than half of that, 14%, and 9.5% in the prophylactic arm or in the reactive arm. Keep in mind that the arm 2 patients were treated early on at grade 1 of severity of the rash usually. So because this rash occurs, as you know, very quickly within weeks 2 and 4, unless you're seeing patients within the first month, every 2 weeks or every week, you're not gonna catch the rash when it's a grade 1. You will catch it when it's already too late. So my suggestion, based on Barb's observations, and I really think it's amazing the way she did this study, is either to treat patients prophylactically or during the first, give them the prescriptions for these interventions so that they have them at home. At the first sign of rash, they start taking their antibiotics. Photosensitivity, I talked about this briefly yesterday. For me, photosensitivity is not really a problem because I live in New York. And previous to that, I worked in Chicago, where there's only about 2 months of summer every year. For you here, it may be a problem, especially with Regorafenib, in which 42% of patients develop this severe photosensitivity. Some of our patients come down south for the holidays or the winter time, and they will tell us that even only after being in the sun for 10 minutes, they will develop blisters in their skin when they are on Regorafenib or Vandetanib. Other agents that your patients may also be on, such as antibiotics, antifungals, such as voriconazole, NSAIDs or diuretics can also cause photosensitivity, but never the photosensitivity as severe that we see with Regorafenib or Vandetanib. Importantly, as I mentioned yesterday, most of this photosensitivity will be caused by ultraviolet radiation A, as you can see here in one patient on Regorafenib, which means that your patients can get a photosensitive reaction even by going to your office in their car, because UVA will go through window glass in their car, or if they're waiting in your office and you have large windows, or they have large windows in their homes, they can develop photosensitivity there as well. So I've talked about using topical steroids because that's what you would do in a photosensitive reaction. One of the most frequent questions I get from my oncology colleagues, which I have the privilege of working with, is tell me what steroid to use in this patient. And this comes up frequently, and it's understandable. You are dealing with usually IV or oral medication, so I hope that this makes it easy for you as to what to do in terms of topical steroids. There's many different potencies of topical steroids, 7 to be precise. You don't need to know all of them. You just need to know 2, a high potency and a relatively low potency. What else do you need to know about topical steroids? Which ones you can use in the body, and which ones you can use in the face or intertriginous areas, meaning under the axilla or in the groin area. Those are the 2 areas of the body that are the only ones that need to be differentiated in terms of strength of steroids. So in areas of the body, like the hands and feet, the legs, the arms, the chest and back, you can use high potency steroids for at least a month, 2 months, and don't have to worry about it, about the side effects and things like that. And it's very interesting because it happens to us in dermatology, where most of my colleagues are hesitant to administer to, especially oncology patients, oral steroids because they're concerned that the immunosuppression is going to lead to a progression of disease. And I see my oncology colleagues that give oral Decadron as jelly beans to their patients, but they're worried about cortisone 10 that you can obtain over the counter in a pharmacy. So I hope this clarifies some of that for you. So you only need to know then a high potency steroid and a low potency steroid that is safe to use on the face and intertriginous areas are listed here, and the high potency steroid. What else could be helpful for you in your busy practices? Many people ask me, what size tube? 15 grams, 30 grams? I don't know how many grams to give these patients. And these names are so complicated because they're usually followed by another name, clobetasol dipropionate, fluosinonide propionate, and all these long names. So if you just learn a trade name, for example, fluosinonide, instead of fluosinonide, you can use, make it easy for comprehend for the patient, Lidex. It's an easier name. So just learn one trade name, and also what you can write in your prescription is use a large container, and the pharmacist will figure out based on the patient's body surface area how much to administer. So I hope that helps you. The other important toxicity with EGFR and MEK inhibitors is the paronychia, this periungual inflammation that can be very painful. It occurs in about 25% of patients. Usually needs to be treated with topical antibiotics or interventions such as nail avulsions or pulling the parts of the nail off, the side of the nail. I wouldn't really recommend interrupting therapy for this toxicity because it takes 6 months to grow a fingernail and it takes a year or a year and a half to grow a toenail. So if you really want to improve this in your patient, you would have to stop their therapy for 2 to 3 months at least. So this needs to be intervened upon if there's discharge culturing it, if not, you doing topical antibiotics or chemical cauterization or referring to a dermatologist for a partial nail avulsion, which is removal or pulling of part of the nail. Believe it or not, that really works very well and patients are very happy. Don't worry, we do use lidocaine before we pull their nails off. I never thought I would be having patients coming back to my office to request nail avulsions, but they actually do because it's what provides them the most relief. And we have been doing it very frequently. And the only side effect that we were having from this intervention was that when we have medical students, they end up passing out in the office. Other than that, it's a very safe procedure. And please, it's important to differentiate that this is not the same as what you see with taxanes. With taxanes, up to 80% of patients on Taxotere will develop some type of nail changes, nail toxicities. You can see here the subungual color discoloration, bleeding. Patients come in, all their nails falling off. You know, it's going to take 6 months for them to grow their fingernails. If it's a woman for neoadjuvant or adjuvant therapy for breast cancer, now she has to go to work with all her nails falling off, pus coming out under her nails. It's really a preventable toxicity that I really would one day not like to see again. So how do we treat this? Once the infection has occurred, culturing, oral antibiotics, and in my experience, you need more than 1 week of oral antibiotics. Do not assume, especially in the lower extremities or in the toenails, that it's always going to be a Staphylococcus aureus. I'm about to publish a paper on this in which we've analyzed the microbes in the toenails of these infections, and we find all kinds of gram-negative organisms. So usually you will need Cipro or Bactrim because many of your patients, when they have toenail infections, they will be associated more with enteric bacteria, such as Klebsiella or Enterobacter bacteria, so they need gram-negative coverage. In addition to that, we recommend for patients to soak their fingers or toes in a solution of vinegar and water. This vinegar, as you know, is acetic acid. It's an astringent, so it will dry the pus and the discharge and reduce the foul smell. Interestingly, the first time I recommended this to a patient, she went to her oncologist and informed her of this, and her oncologist asked her if it was white vinegar or balsamic vinegar. Obviously, it was white vinegar. We recommend a dilution 1:1 for 15 minutes every evening. And it's a very old, inexpensive remedy we know in dermatology. Another way the one way to prevent this, though, is by having their patients cool their hands and feet during the infusion of taxanes and Docetaxel and Paclitaxel. So this study that demonstrated this was published in JCO in 2005, 11 years ago. How many people use any cooling of the hands and feet in patients that even after they develop nail toxicities? I think almost no one uses this still. And this intervention really did not catch on because it's difficult to keep these gloves and they thaw after 45 minutes. You have to have dry ice or a freezer. So what we ended up doing is having patients use bags of ice during their infusion. And we have found with this method that patients are not having. There was an abstract published in AACR several years ago showing that they had similar efficacy. And serendipitously, we have found that patients report less neuropathy by using this intervention. And I know that there is a project underway. Dr. Loprinzi at Mayo Clinic is spearheading a project to test ice packs during the infusions to prevent neuropathy. In my experience, I have to say that when patients do use the ice bags, this was something that a patient informed me about. I didn't find it myself. She told me the first time I had Taxol, I had horrible neuropathy. This time I had the ice packs, I had no neuropathy. So it makes sense. You're causing peripheral vasoconstriction. You don't get Taxol in the fingertips or toe tips, and you don't get the toxicity. As you can see here, the nail toxicity in the hand with the glove was not present, whereas in the other hand it was. Dry skin is probably one of the most common things you will see in your patients if you look close enough. You can see here it varies depending on which agent you are using. In the hands, it can present these very painful fissures. So it's important to use a moisturizer. So fragrance-free detergents and soaps are key. Short showers. And many people are confused as to what moisturizer they use. I know for some reason people like to use very thick, heavy moisturizers, which are ointments. These are oil and water type of compounds. These usually come in a tub like Aquaphor or Vaseline. Although they are very good in retaining moisture in your skin, they are very difficult to spread and to apply. And especially, this is something we were talking about yesterday, especially in men, in adult men, you will have some of your patients, as I have had some of mine, who have literally never applied a cream onto their skin. And when now you are asking them to apply this greasy ointment all over their bodies twice a day, that's not going to happen. So what can you do in these situations? You can either use a lotion, which is more easy to spread, or what I do in most cases, and I found to be most effective, and I don't think there will ever be a study for this, is that when a man comes in with his wife, I just ask them to either, after the man takes a shower, for her to take a spray of Vaseline, moisturizer. Vaseline has these sprays, and spray like that, like she would do with a child, and spray them like that. And I think that's one of the most effective ways, because men, we don't like applying creams. As a dermatologist, I have to admit, I don't like applying creams. In addition to that, areas that are very cracked or dry, make sure that the moisturizer contains either of these ingredients, ammonium lactate, salicylic acid, and urea. Talk to your pharmacist, because some of these are prescription items, and data from the dermatology literature has shown that even if you prescribe a moisturizer, even if you recommend a moisturizer, if you write a prescription for it, and there are moisturizers that are prescription items, the patient will be more likely to use it than if you just tell them, go to the drugstore and get a moisturizer, and the person goes to the drugstore and sees 200 different types of moisturizers. Going on to a different toxicity affecting the hands and feet, the hand-foot syndrome, especially to capecitabine, is important, as you know. It's important to know that vitamin B6, there was a randomized study showing that it was not effective, so vitamin B6, pyridoxine, is not effective. With Doxil, cooling of the hands and feet, or Decadron, but cooling is easier, I feel, and is actually more preventive than reactive. The only study that has shown any benefit in the prophylaxis of capecitabine-induced hand-foot syndrome is this study, in which celecoxib 200 milligrams twice daily was given to patients, showing a reduction of more than 50% in hand-foot syndrome. The hand-foot syndrome to capecitabine is different to the hand-foot syndrome to the tyrosine kinase inhibitors, as listed here. The highest offender, which is Regorafenib, recently approved for CRC. You can see also, of course, with Sutent and Sorafenib, you see it, painful blisters. I've seen patients coming in wheelchairs because of this painful toxicity. So what can you do about this? Here in the feet, these painful blisters. So reactively, after it has occurred, what I do is I treat patients with a high-potency topical steroid. Thankfully, there are topical steroids that come as foam, so they are not as greasy. So a person that wants to use their hands and feet, they can apply a foam. It's like a mousse, so it dissolves immediately. At night, I have them apply a topical agent that will soften the skin. And then during the daytime, this trick that I learned from a patient also, and patients are such great teachers, is to use lidocaine patches. This patient had a lidoderm patch for another painful condition, and he ended up cutting the patches and placing it in areas of the feet where it hurts, and he could now walk. And I recommend this for patients to use in the mornings when they want to walk, and it really works great. What has been shown in the randomized setting? Urea 10% 3 times a day against moisturizers in a Sorafenib study for HCC, showing a 15% reduction in all-grade hand-foot skin reaction. So if you're going to do anything prophylactically, this is the only positive data. This was published in JCO last year. So urea 10% 3 times a day. It's an OTC product. So that's one thing that would be important to know. We'd like to move on to different toxicities. Immunotherapies, the novel agents, ipilimumab, nivolumab, and pembro, approved for, as you know, melanoma, renal cell carcinoma, and lung cancer, squamous cell lung cancer. So what is important about these agents? That the toxicities usually don't occur as rapidly and are different than with the other targeted agents. You will see a rash and pruritus, we will talk about, liver toxicity that occurs later on, diarrhea that occurs after about the 4th to 6th week, and you also get other endocrine abnormalities after about 2 months of therapy. What about the rash to immunotherapies? It's very different than the rash to targeted therapies that target the EGFR. The rash to these drugs is more of a maculopapular rash, looks like measles, affects the entire body, spares the face and hands and feet. It occurs in about 20% of patients to 20 to 40% of patients if you look close enough. What you see histologically is a nonspecific inflammation. Treatment for this usually consists of oral antihistamines for the pruritus and topical steroids for grade 1 and a combination of topical or oral steroids for grades 2 or 3. Because I think once this rash goes to grade 2 or grades 2, it's inevitably going to go to grade 3 and it's going to be severe. This rash is frequently associated with pruritus. A study conducted by 2 residents with me, Courtney Enslin and Johanna Valentine, listed here. They did a great study in which they analyzed the incidence of pruritus to all the targeted agents we published in one of our dermatology journals, showed that this was associated with decreased quality of life, and also, as you can see here, the scratch marks in these patients. And it is notable that the pruritus to these immunotherapies is not always associated with a rash. So we will see a patient that says that the itching is driving them crazy, but you don't see a rash really. So you have to treat them usually with systemic agents in those cases. So what agents do we use? We use either topical or oral steroids or antihistamines, but also there's been some recent data that the agent that you use to prevent chemotherapy-induced nausea and vomiting, a Prepitant or a MEND, is effective for this pruritus. GABA agonists, pregabalin and gabapentin, or phototherapy that is done at a dermatologist's office. This figure illustrates also that the scratching can also be associated with these painful fissures associated with the dryness. And as I was mentioning before, in some patients, you don't even see a rash. You just see the scratch marks called excoriation. So keep an eye out for those. A patient will tell you that they have severe rash, and the only thing you can see really is the scratch marks. But believe those patients, because part of my practice is administering quality of life questionnaires to these patients. And in patients receiving immune checkpoint inhibitors, I'm administering a quality of life questionnaire called, very imaginatively by the creators, Itchy Quality of Life Questionnaire. So what this quality of life questionnaire is it has 22 questions as to how in the past week itching has affected a person's quality of life. I hope none of you have ever experienced itching, but itching is something that people literally say that they are going crazy because they cannot sleep and they want to tear their skin apart. So when I administered this to one of the recent patients, I just wanted you to see that a number of questions you may not be able to read from there, so I just wanted to point your attention to one question, which is question number 16, which reads, "My itchy skin condition drives me crazy and nuts." And he added 5 X's here on the most. And then we also are able to, and this man had no visible rash. And you can see here, we have asked him to mark where the itching was. You can see it's all over the body. So what does this tell us also? If you have a patient that has itching in all of these parts of the body, and you try to prescribe a topical cream for that, that's not going to work because no one is going to apply cream in all those areas, and it's probably not going to be as effective, so you need an oral agent. So GABA agonist, a Prepitant, or prednisone. I'm going to run quickly through toxicities that are outside of dermatology, because you know this better than I do, but just to emphasize that these toxicities do not occur by themselves. So the diarrhea and colitis is also a big problem. You can see here imaging studies and showing the inflammation on histology. Treatment at our institution usually includes corticosteroids, TNF inhibitors, infliximab when they do not respond to corticosteroids. If there is any pain or bleeding per rectum, of course, they need to be investigated, and infectious panel needs to be instituted. There was a study published several years ago with ipilimumab. They gave patients prophylactic budesonide, and it did not work, unfortunately. Hepatitis is also a common toxicity in these patients, especially when combined with other agents. About 5% of patients or higher If you look prospectively, usually treated with corticosteroids or other immunosuppressive agents. Infliximab is not recommended for hepatitis because it has its own hepatotoxicity. Pneumonitis is also a toxicity that has been reported, very significant, especially if you're going to use these agents in a patient with lung cancer. Treatment consists of corticosteroids or other immunosuppressive agents that you know how to use better than I. So I will just show you how in this patient there was patient 1 at 22 weeks, and then how the worsening of as you can see here, the infiltrates became over time, and these other 2 patients when they developed pneumonitis. Endocrine toxicities usually characterized by headache or fatigue, so it's important to check the different axes which can be affected. This is a patient, for example, that had hypophysitis. You can see here at baseline, 4.5 millimeters pituitary gland, and then increased to 10.8 millimeters. So it's important to check biochemistry, imaging, as well as a physical exam because antibodies are negative. So treatment, supplementing thyroids, corticosteroids, when it's the other glands that are affected, the adrenal gland can also be affected, and fluid and electrolytes. So this patient had a headache and fatigue. For comprehensive detail or algorithms as to how to manage these toxicities, a paper was published in Annals of Oncology this year by a group that consisted of some members of our institution that I had the privilege of working with, and Jarushka Naidu, who is currently at Johns Hopkins. So you can see in this paper in Annals of Oncology very clearly defined by grade of severity what interventions you can use quickly and easily in your practice to manage these adverse events. People were concerned that because these agents stimulate the immune system, whether by treating patients with oral steroids you would decrease the efficacy. It appears that when you, as reported in these 2 studies, patients on Ipi or Nivolumab, when you give them oral corticosteroids, there is no difference in terms of their overall response, as you can see here. It appears that using steroids does not affect their efficacy. On the other hand, it appears that when patients develop rash or vitiligo or skin depigmentation, as indicated here in the black line compared to the gray line, they appear to have a better response. So patients that develop a rash or vitiligo with immune checkpoint inhibitors appear to have a more robust immune response, which leads to a better clinical outcome. This is how vitiligo manifests. This is more common in patients with melanoma, but you can see depigmentation of the skin. You usually don't need to treat this because patients are usually not bothered by this. Recently, the combination of Ipi and Nivolumab was approved for melanoma based on increased PFS. And as you can see here, it's also associated with a much greater toxicity. When you combine Nivo plus Ipi, you get grade 3 adverse events in 55% of patients, compared to 16 and 27% of patients on Nivo and Ipi respectively. So expect many of your patients, if you treat them with Nivo and Ipi, to go to the emergency room and to have severe toxicities. Interestingly, however, of the 70% of patients who discontinued this combination due to adverse events, they had a response. So again, their immune system is probably more robust, causing greater toxicity, but their cancer is improving more. So in summary, with PD-1 inhibitors, the Nivo and Pembro and the others, many others coming down the pipeline, the toxicities are the same as Ipi, but less severe, and you have the addition of the pneumonitis, which you know very well how to treat. Important to keep in mind, we heard Dr. Murphy's presentation this morning, and she will be speaking later on about radiation. So important to keep in mind that it's very challenging, and be careful combining these agents with radiation. This is a young man treated with Regorafenib, and he was given whole brain radiation simultaneously. The same way that you would like these drugs to be radiosensitizing in the tumors, they are radiosensitizing in the skin. So this patient had, as you can see here, brain edema along with edema of his scalp when he was treated with Regorafenib plus radiation. And this patient had a radiation recall after he was radiated for a MET here in the elbow and given pembrolizumab later on. Many studies have been done to prevent radiation dermatitis. Just wanted to say that the only studies that have shown to be positive are with the use of prophylactic topical corticosteroids for the prevention of radiation dermatitis, most of which have been done by Dr. Loprince's group at Mayo Clinic. So I encourage, if you have patients with breast cancer receiving radiation, to use topical steroids such as mometasone for the duration of the radiation once daily. And there was a small study done in Turkey in which Silvadene was used 3 times weekly, thrice a day, showing benefit as well. Because I feel like we all agree that what was initially described, especially in the trial in which that led to the approval of cetuximab plus radiation, that there was no greater toxicity when you add cetuximab with radiation, was something that was very hard for us to understand. How is it possible that by adding an agent such as cetuximab that affects the skin so much to an area that is radiated, you will not get greater toxicity? So there were a number of reports and meta-analysis subsequent to that contradicted those claims from that trial published in the New England Journal, showing that indeed you get greater toxicity when you combine an EGFR inhibitor with radiation. And you can see this very clearly in this patient receiving cetuximab plus radiation, having a much greater toxicity. And there was a recent paper in JCO also showing a much greater toxicity when you combine Erbitux with radiation. And this is something that I feel that, that these patients should be treated prophylactically. So I'm going to conclude with hair changes. So we talked yesterday about hair, how patients will have, on cytotoxic agents, will lose their hair. It's a very common toxicity, usually because the anagen growth phase of the hair follicle will be inhibited. There are several mechanisms that I will not go into detail. Suffice it to say that it's normal to lose about 100 hairs a day, but people on cytotoxic agents lose much more, and usually it's in the growth cycle. And in the growth cycle, you can see here, usually occurs after the second cycle of chemotherapy, and then the hair starts to recover after about 2 to 3 months. However, in some patients, the hair never comes back. And I had mentioned last night, and this is something that I feel is so important because this has become one of the major areas of my research and clinical practice now, that there's a subset of patients in which the hair never fully comes back. And despite the amazing things that you as oncologists and oncology nurse practitioners and nurses do for your patients, I mentioned yesterday, the only time I have ever seen a patient upset at their oncologist is when the patient comes with a persistent alopecia after chemotherapy and says, they told me that my hair would fall off and I would grow my hair the same as before, and it's been 3 years after Taxotere, and look at my head now. Or I'll show you something in the next slide. So what is the incidence of this? With Docetaxel, there are reports that occurs between 12 to 32% of patients. We don't know the incidence of this in some of the most commonly used regimens at our institution, such as AC and Taxol. This is what I wanted to mention also as to patients that were disturbed by. When you place your breast cancer patients on hormonal endocrine therapies for 5 to 10 years, few patients are told that their hair might become thin. It turns out that between 22 to 31% of patients will develop some degree of hair thinning or loss. These are other upset patients. Highest incidence in a meta-analysis we conducted was shown with tamoxifen, and the lowest with anastrozole. But this has not been studied prospectively. For this purpose, we are doing a study called the CHANCE study, a prospective longitudinal study of chemotherapy-induced hair changes in alopecia, skin aging, and nail changes in women with non-metastatic breast cancer. So in this study, we feel it's unique because there is no prospective study that has determined the incidence of these changes in women treated in the adjuvant or neoadjuvant setting. So, and why did we call it CHANCE? Because we base that acronym on that long title, but so that patients can ask you in the future and you have an answer for them, what are the chances that I will permanently lose my hair or that my hair will be thin from chemotherapy or when you place me on an AI or tamoxifen? So the primary endpoint will be the incidence and severity of permanent chemotherapy-induced alopecia or hormone therapy-induced alopecia. So we'll be taking standardized photos of patient's scalp, as you can see there. We will also be taking these special pictures that allow us to measure the diameter of hair shafts and the number of hair follicles in a small area of the scalp. And this is a very simple procedure. For some reason, people love to have a photo of their scalp taken close by like this, so patients have actually liked to participate in this study, so I don't think we're gonna have a problem enrolling. We've already started enrolling. We have about 30 patients, and we're going to have a total of 500 patients with early stage breast cancer in 3 different cytotoxic regimens, endocrine therapies, or normal controls as listed here. And we will follow them for 3 years after they complete their therapy. We will also follow other changes that anecdotally have been reported by patients, such as aging of the skin. So when you induce an iatrogenic menopause in these women, it appears that they age more. You also develop these nail changes that we discussed before and that can be permanent. So we will be taking pictures of their faces like this that we will be able to grade and using a special device, standardized pictures of the nails here as well. We will also be measuring quality of life with different questionnaires and determine if there are any polymorphisms that lead to people having a greater risk for permanent toxicities. But what can you do now? Well, there was one study published from MD Anderson that you can prevent chemotherapy-induced alopecia that investigated that by using minoxidil or Rogaine 2% twice daily to placebo. This was a very small study, and the only positive aspect of this study was that they found that the maximal that time of complete alopecia was reduced by about 50 days, from 105 days in the placebo to 57 days in the minoxidil arm. So essentially, in other words, you can tell patients that instead of having complete hair loss for 3 or 4 months, you will have it for about 2 months. That's the only positive thing about this study. On the other hand, I've treated a number of patients that have endocrine therapy-induced alopecia or hair thinning, such as listed here or shown here, and you can see the improvement after several months of using Rogaine 5%. This is a patient on an anastrozole. This is another lady that she was on letrozole, or she is on letrozole. You can see here the improvement in hair growth after using minoxidil twice daily. Latisse is another product that can be used in your patients that lose the eyebrows and the eyelashes, something that we will also be measuring in our study. And this is a small study published from Duke showing that by using Latisse, which is bimatoprost on the patient's eyelids, you can increase the length and the thickness of the eyelashes more than twofold if they develop alopecia during chemotherapy of their eyelashes, which is a problem for some women, and they feel it's a problem to hide. But really, the reason I wanted to bring this topic briefly is because there's been a lot of talk recently as to maintaining your hair during therapy, and importantly, there are several types of cold caps. I will not spend too much time on this, just to say that some are the ones that patients can bring into your office, logistically a nightmare, and the other ones are the ones that you can have in your office, one of which was recently cleared by the FDA, called the DigniCap system. And this DigniCap system was studied in a 2-arm study in 117 patients with early-stage breast cancer, showing a 70% success in terms of patients. 70% of patients lost less than half of their hair. And you can see here the regimens that were used usually was Taxotere or some patients with Paclitaxel. Unfortunately, no patients receive anthracycline-based regimens, which I feel are probably the greatest offenders here. This is a comparison, a patient that did not have cooling of her scalp and a patient that had cooling of the scalp, as you can see here. And I've seen some of these patients. It's remarkable how some of them can really maintain their hair. There's been some concern about safety because one can think that they can develop scalp mets. A paper published from the Netherlands showed that by analyzing over 50,000 records of patients where scalp cooling is widely used in Australia, the Netherlands, and some other European countries, showed that the incidence of scalp mets was no different with a similar survival, and furthermore, the overall survival was measured in a subsequent study and was no different between the cooled and the uncooled patients. So there is no concern for scalp mets. And other agents that were not thought to cause alopecia, such as targeted agents, BRAF inhibitors, also lead to hair thinning, as you can see here, although of different proportions. So important to mention, if you treat patients with this, that they may develop hair changes. Paradoxically, with EGFR inhibitors, what you see is increased growth of hair on the face, and this is especially a problem for women. But I would like to say that not everything is negative. The one side effect of the skin and hair that patients actually like is that their eyelashes with EGFR inhibitors grow very long and curly. So that patients actually like. But one has to be careful because sometimes they can grow inside the eye, causing corneal erosions and ulcerations. And hair color changes, I mentioned some yesterday, but with the immune checkpoint inhibitor, similar to the vitiligo, they can have depigmentation of the hair, which usually does not require treatments. Please don't forget your patients. The remarkable things and amazing things you do for your patients now mean that most of your patients will survive and will live a long life. So these patients can also be left with sequela of treatment, including, as you can see here, problem scars, hypertrophic scars, the permanent or persistent alopecia. Childhood cancer survivors or people who live a long time after radiation will develop skin cancers in their skin, or other cosmetically unpleasant changes, many of which can be treated by a dermatologist, improving their quality of life and allowing patients to get back on with their lives. There's a textbook on this topic, if you are interested, published by myself and many other colleagues that has illustrations on many of these toxicities, and it should be available in the library associated with your institution. So to conclude, adverse events are common to targeted and immunotherapies. An early and proactive approach is critical to maintain quality of life. And these adverse events, again, will increase in importance as the wonderful things you do with your patients, keeping them alive for so long and living well, they forget about other toxicities because they are so minimal. Now they can worry about these quality of life issues, which will increase the longer they live and when you combine therapies. Thank you very much for your time.